behalf of my colleagues to present the first data from the randomized phase 3 trial of osimertinib as adjuvant therapy in patients with stage 1B to 3A EGFR mutation positive non-small cell lung cancer after complete tumor resection, the ADORA trial. Next slide, please. Well, lung cancer is the leading cause of cancer death worldwide, with more than 1.7 million deaths annually, more than breast, prostate, and colorectal cancers combined. Non-small cell lung cancer represents 85% of these lung cancer cases, with an estimated 30% of these patients presenting with a resectable disease at diagnosis, where you would cut it out. I've shown some schema to help describe this. On the left, you can see stage 1B disease. You can see a tumor in one lung, the right lung. On the right, you can see stage 2 and stage 3A. There you have the tumor in the lung, but then you have regional lymph nodes in stage 2 and more progressive lymph nodes in stage 3. On the next slide, what you can see is that even though these tumors are resected, patients will still recur. We have adjuvant chemotherapy that has been well defined with drugs such as cisplatin, and these are used in these settings. However, the 5-year overall survival benefit with this therapy is only about 5%. And of course, there are toxicities. Overall rates of disease recurrence following surgery and adjuvant therapy, therefore, remain high. You can see in the stage 1B, 45% of patients will recur at 5 years. In stage 2, 62%, and in stage 3, 76%. So clearly, we need new therapies. Next slide. Well, certainly EGFR tyrosine kinase inhibitors have redefined the way we think of lung cancer in advanced metastatic lung cancer. These have been studied over the course of 20 years. I was involved in some of these studies back then, and it was just marvelous the effect that these had in patients, 1997. But then it wasn't until 2004 that we realized that there were specific mutations in the epidermal growth factor receptor gene, so we can target these drugs precisely to these patients. And that resulted in a number of drugs, including osimertinib, which is a third-generation tyrosine kinase inhibitor against EGFR that has significant results in the metastatic setting as a frontline agent. So now what we're doing in this trial is we're taking the drug from the frontline metastatic setting and we're moving it to the adjuvant setting. We're moving it earlier in patients' disease to hope for an even better benefit. Next slide. Well, here's the trial. It's a randomized phase 3 trial, ADORA. On the left, you can see the eligibility criteria. Basically, patients with stage 1, 1B, 2, or 3A disease. Patients were stratified by their stage, by the type of EGFR mutation they had, or their race, Asian versus non-Asian. This was a multinational trial. Patients were randomized to osimertinib, 80 milligrams once a day, or to a placebo. If they were candidates for chemotherapy, they had this before they went on the oral agent. The planned treatment duration was 3 years, and the treatment continued until the disease recurred. The primary endpoint was disease-free survival. Well, this trial, as most trials are, was monitored by an independent data monitoring committee. They had a planned meeting last month. At that meeting, they were not expecting to look at the efficacy results of the trial. However, the results looked so good that they decided that the trial needed to be unblinded because of the results I'm about to show you in a moment. Next slide. Well, if I was on the committee, I would have done the same thing. These are extraordinary results. These are the first results from this study. And what you can see is the blue curve on top are the patients who got osimertinib. The yellow are the patients who got the placebo control. That curve looks very similar to what you would expect from other studies. Look at the separation of these curves early on and the distance between the two curves throughout the course of this plot. The hazard ratio is 0.17, which means that there's an 83% reduced chance of disease recurrence. This was much better than expected and certainly is something that's going to help patients. Next slide. Another key secondary endpoint of the trial, was adding in the stage 1B patients. So even when you look at the results with the 1B, the earlier stage patients, and the 2 and the 3A, you still have curves that look like this, much separated, and the hazard ratio is 0.21, now a 79% reduction. So a little bit less because you have many patients with earlier disease, but nonetheless, still a very positive study, suggesting that this study and the drugs will be useful in these patients as well. Next slide. Well, here you can see a subgroup analysis. This is what we call a forest plot. The vertical line in the center is at 1. Anything to the left means that the result favors the study drug, the osimertinib. And you can see in nearly in fact, every category, and I can tell you I've done many of these over the years, you almost never see this. In every category, sex, age, smoking status, race, the stage of disease, divided equally, by the way, 1/3 in each stage in the trial, EGFR mutation status, whether or not the patient received chemotherapy, all of the results are favoring the study drug, osimertinib. Next slide. Well, of course, the next question is, was the drug tolerated? The answer is yes. The median duration of exposure for osimertinib was 22.3 months, and for placebo, 18.4. You can see the toxicity results shown here. The main toxicities from drugs like this are usually diarrhea, dry skin, rash, and what you can see is that most of the toxicities were low grade, grade 1 and 2. If there were any very high grade toxicities, as you can see with a black square, very low percents, 2, 1, 2%. So really very well tolerated. You always worry about a trial in Asia and a trial with an EGFR TKI about interstitial lung disease, ILD. There was only a 3% rate of this, and it was all low grade. Cardiac prolongation with QTC was reported, but it was quite minor and all low grade. Next slide. So what I hope I've showed you is that adjuvant osimertinib is the first targeted agent in a global randomized trial to show a statistically significant and clinically meaningful improvement in disease-free survival in patients with stage 1B, 2, 3A, EGFR mutation positive non-small cell lung cancer. Overall, there was a 79% reduction in the risk of disease recurrence or death with osimertinib. Osimertinib versus placebo at 2 years had DFS rates of 89 versus 53% respectively. A consistent improvement was seen regardless of whether patients received prior adjuvant chemotherapy. As I just showed you, the safety profile was consistent with the established safety profile of osimertinib, and the median duration of exposure was 22 months. Therefore, adjuvant osimertinib provides a highly effective, practice-changing treatment for patients with stage 1B, 2, 3A, EGFR mutation-positive non-small cell lung cancer after complete tumor resection. On the next slide, I just want to give some personal reflection. I was the chair of the ASCO Communications Committee in the early 2000s, and I remember sitting at the press conference where Herceptin was first presented as an adjuvant therapy in breast cancer. And George Sledge made the comment, biology has. That stays with me, and I would say biology has now spoken again. If you look on the left, we've taken lung cancer, a very common and deadly disease, more than 2 million cases worldwide. Approximately 30% of the cases are stage 1 to 3A that could be resected. And then we take EGFR mutations, which are about 10 to 20% of patients in the United States and 30 to 40% in Asia. We've combined those together. And then if you look at the middle, we've taken on the top the best multimodality therapy, the therapy that all of the physicians that come to ASCO strive for, where surgeons and medical oncologists work together. You cut out the tumor, you give your best chemotherapy, you do your best procedures, but still it's not good enough. So then you take targeted therapy, the EGFR inhibitors, and the third generation drugs, the ones that are most well tolerated, that can be given for this longer period of time, and you blend them together. And what do you get? You get the right. You get the patient. And it's all about the patient and keeping the patient from having morbidity, having them live longer with better quality of life. You have a patient who avoids metastatic disease. You keep the tumor from spreading after it's been resected to the brain, the liver, and the bone. I can't help but think now nostalgically about my mentor, Josh Fidler from MD Anderson. He passed away earlier this month. He taught me and he taught all of us that it's metastasis. It's a spread of tumor that kills patients. Drugs such as this, based on biology, given to patients at the earliest possible time, can prevent those metastases and allow patients to live longer with better quality of life. Thank you very much.